Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club on transplant social worker and donor financial assistance to increase living donor kidney transplants among African Americans. The talk study is hosted by the AST's Living Donor and Psychosocial Communities of Practice. Our moderators for today's session are Dr. Brian Lee from Dell Seton Medical Center, UT Health Austin, and Dr. Reem Daloul from Wexner Medical Center, Ohio State University. However, before we begin the main presentation, we do have a few housekeeping notes to help you engage with today's session. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. This journal club is being recorded, and the archive will be available on the MyAST website within 2 to 3 business days after the live session. Please note, your lines have all been muted so that only the presenters can be heard clearly for the archive recording. If you have a question for our panelists during the Journal Club, we encourage you to participate by using the Q&A button in the Zoom webinar panel. Questions submitted via chat may be missed during the presentation. If there are questions we do not have time for, we will either answer them individually offline, or we will post a full question with the answer on the website following the Journal Club. Finally, when you log off at the conclusion of today's Journal Club, you will see a link to a short evaluation survey to complete. Please fill out this survey to help us keep our content current and engaging. I now turn the session over to our moderators, Dr. Daloul and Lee, to begin the presentation.
Thank you so much, Brian, for that introduction. And thank you everyone for attending today's session. I wanted to take this opportunity to thank the American Society of Transplantation, Living Donor Community of Practice, and the Psychosocial and Ethics Community of Practice for sponsoring this event. So without further ado, I wanted to introduce today's prestigious and distinguished speaker. I want to introduce Dr. Ebony Boulware, who's the Anne Lyon Duke Distinguished Professor of Medicine and the Chief of Division of General Internal Medicine and the Director of the Duke Clinical and Translational Science Award and Vice Dean for Translational Sciences. Dr. Boulware's research interest is mostly in improving health and health equity for individuals and also communities affected by chronic health conditions. And as a national thought leader in health equity, she has identified patient, clinician, system, and also community-level barriers that result in disparate outcomes for Black and other minoritized individuals. And with that, I'm going to turn this over to my co-moderator, Reem Daloul.
Good afternoon, everybody, and thank you so much for joining us. I have the pleasure to introduce Dr. Ashley Henderson, who's going to be our discussant for the session today. Dr. Henderson is a behavioral research science, currently working at the United Network of Organ Sharing. She received her PhD in social and behavioral health sciences from Virginia Commonwealth University School of Medicine and joined UNIS in 2022, just before the epidemic. She's been doing very exciting and very important work with UNIS on improving health equity and reducing disparities and marginalized communities. She's also been very active in working on access to transplant score, which target to improve health equity across marginalized communities. So we're very happy to have her and to have her expertise with us tonight.
So I think with that, we're going to welcome Dr. Boulware and have her tell us a little bit about this very interesting paper. Thank you.
Great. Thank you so much, everyone. Thank you for the kind introduction. And it's really a pleasure to be here with you on this journal club to talk about this study that we did, transplant social worker and donor financial assistance to increase live donor kidney transplants among African Americans. I have no conflicts of interest for financial relationships to disclose. I'm going to briefly, as I walk you through this work that we did, just set the stage by reviewing live donor kidney transplant racial inequities, focusing in on inequities among Blacks compared to others, review some of the common recipient and donor barriers to live donor kidney transplantation faced by African-American individuals, and then go through the findings from the talk study, which was a randomized controlled trial, and hopefully we can have a robust discussion at the end on implications for the future. So the overarching message behind the background slides I'm going to show you are that African-American individuals are less likely to receive live donor kidney transplants, and there's lots of evidence on that. Education, logistical, and financial resources may be barriers for African-American individuals to get transplanted, and maybe face more frequently for African-American individuals who have end-stage kidney disease. And because people wait for significant time periods on the waiting list once they've received their transplant evaluations, those people who are waiting on the deceased donor kidney waiting list may be ideal for facilitating live donor kidney transplants, which would be a way for them to get a transplant, an optimum transplant, and bypass their waiting on the deceased donor kidney transplant waiting list. I just want to visit some recent work looking at the association of race and ethnicity with live donor kidney transplantation in the United States. This was data from 1995 to 2014. And what the authors did was look at differences in the rate of live donor kidney transplantation during 4 time periods, actually, from 1995 to 1999, and then 2000 to 2004, 2005 to 2009, and 2010 to 2014. And what I've highlighted here are the key findings, which really just highlight the fact that Black individuals have had lower hazard of receiving a live donor kidney transplant when compared to white individuals. And that was true in 1995. They had 55% lower hazard or chance of receiving a live donor kidney transplant compared to white individuals. And then, though, if you looked forward in time, meaning more recently, 2010 to 2014, the disparity actually got worse, with Black individuals having a 73% lower hazard of receiving a live donor kidney transplant compared to white individuals. So not only is there a disparity, but the disparity seems to be getting worse, which is a distressing situation, as we all know. So why is this, and what are some of the potential reasons? And if the why is probably multifaceted, and I won't get into all of the various determinants of probably why this is, but there are some specific areas that this study really looked at. First off, one of the questions was whether African-American individuals have difficulties identifying willing and medically eligible donors. So obviously, to get the live donor kidney transplant, you must have donors. And so our lower rates of live kidney donors, because the potential recipient actually has difficulty identifying individuals who are medically eligible and engaging them. The second question is logistical and financial barriers. The third issue is around knowledge around live donor kidney transplant. And then how do people initiate and sustain discussions about live donor kidney transplants with their physicians and with potential donors who are often their family members. So with regard to African-American individuals needing to find more potential live donors, the question is actually, do they need to? And we know that there's a racial disparity in chronic kidney disease risk factors. So African-American individuals have up to 2-fold greater risk of diabetes, which is the #1 cause of end-stage kidney disease when compared to white individuals. African-American individuals also have a greater hypertension prevalence, and they also have greater risk of end-stage kidney disease itself. So one interesting thing to consider is whether the pool of available donors is actually smaller for African-American individuals who are in need of a kidney transplant for live donors. And does that mean then that African-American individuals who seek a live donor kidney transplant need to reach out or engage more potential live donors as part of the process or journey toward us receiving a live donor kidney transplant? Another thing to consider is knowledge. There have been many studies showing that race differences in knowledge of kidney replacement therapies among patients with chronic kidney disease. This was a study done a long time ago among patients with stages 3 to 5 chronic kidney disease enrolled in a study, they were all receiving care in a chronic kidney disease practice. And the investigators just asked folks about their knowledge of hemodialysis, peritoneal dialysis, and transplant. And then they looked at these knowledge rates by race, white individuals and African-American individuals, and found that overall knowledge of various treatments was suboptimal overall, but it was notable that African-American individuals had lower rates of knowledge of all these different modalities of treatment as well. And there have been other studies done, one's coming to mind from Dr. Amy Waterman that they did at Washington University, showing that that there often are lower rates of knowledge among African-American potential recipients of a live donor kidney transplant, and those lower rates of knowledge are associated with lower rates of kidney transplantation. There's also, as I mentioned, what about discussions? Discussion about live donor kidney transplant is a pretty critical element. In order for somebody to get a live donor kidney transplant, they need to talk with their physician, they need to talk with any potential donors in their families or people that would help them identify potential donors. This was a study that that I did with my research team and I did years back, asking individuals who were on hemodialysis already about whether they were interested in receiving a live donor kidney transplant, and then whether they'd spoken about that to their spouse or their child. And what we found, and I'm not showing here, is that nearly 100% of the patients said they were interested and desired a kidney transplant. I think it was very high rates, like around 90+%. But when we looked at how many of those people had actually discussed kidney transplantation with their, oh, excuse me, I'm wrong. So actually 71% said they desired a transplant and 61% said they did not desire a transplant. So my memory is wrong and I'm looking right at the slide. But so the rates of wanting a transplant though were pretty high. So somewhere between 60 and 70% said they wanted 71% said they wanted a transplant. But when you ask people about did they discuss transplantation with their spouse or with their child, you could see that even among those who said they wanted a transplant, the individuals in the blue, only 40% had spoken to their spouse about it, if they had one, or their child about it, far fewer. So the rates of discussion with physicians, with their physicians and with spouses and children were low. I'm actually going to go back because I realize I've had these slides for years and I may have said this wrong. So I'm going to repeat this slide because I did do it wrong. Okay. So this is the rates of patients and family discussion with the physician, the patient's physician about transplant. So I'm reminding myself that I actually was correct, that it was around 90% of people who said they wanted a transplant. And then we asked the patient, the spouse, and their child whether they had talked about transplant with the patient's physician, if they wanted a transplant, whether they, according to whether or not about live donor kidney transplant, whether or not they, regarding whether or not among people who said they wanted a transplant, among people who said they did not want a transplant. So what this says is among people who said they wanted a transplant, the patients, only 71% of the patients had talked with their physician about it. And then among the people who said they did not desire transplant, 61% said they'd actually talked to their physician about it. Now, when we asked the spouses separately about whether they had talked with the patient's physician about the patient wanting a transplant, only 40% said they had talked with the patient's physician. And when we asked them about, even among those who said they didn't want a transplant, 44% had talked with the patient's physician. And then when we asked the patient's children, only 14 and 20% had said they'd spoken with the patient's physician. So the point of this slide is to say that even when patients want a transplant, the patient and the potential donors in their family are not likely to speak out to the physician proactively. At least in this study, we found that. And then this slide looks at the rate at which they talked about live donor kidney transplant among each other. So we asked the patients, had they discussed this with their spouse? Had they discussed this with, we asked the spouses, had they discussed it with the patient? We asked the patient, had they discussed live donor kidney transplant with the child? And then we asked their children, had they discussed it with the patient? And so what we found were, first off, that when we asked patients, had you discussed live donor kidney transplantation with their spouse, 46% said they had discussed it. When you asked the spouses separately, had they discussed it with the patient, 60% said they discussed it. So what's interesting here is that even there's disagreement as to whether they had the discussion or not within families. And then a similar type of disagreement around the patients and the child. So there's something about this slide which shows that, the discussions are not happening optimally. So 100% of the families are not having the discussion, even when patients want to have a transplant. And then when they think they've had a discussion, there's disagreements as to whether they've actually had a discussion. And one wonders if patients may have said they kind of felt they discussed it, but maybe not completely, versus when the spouses and children felt like they had a complete discussion. We didn't go into that kind of depth, but this gets to the point that family discussion around live donor kidney transplant is suboptimal. Okay, moving on to financial concerns. We know that financial concerns are concerned to particularly African-American potential recipients and donors. We did, in some of our own studies, we asked people about the types of concerns that they have about live donor kidney transplant. And some of the concerns that African-American potential recipients and donors have brought up in the past are concerns around loss of a job for the potential donor, or concerns around being able to get health insurance in the future if one were to donate a kidney. And then patients and their family members have also expressed concerns regarding the expenses of transplant and transplant-related health, live donor kidney transplant-related expenses as a concern. Years back, we'd done a national study asking people about financial reimbursement for live donor kidney transplantation, and in particular for living donors. And we asked people about various different types of reimbursement people might want to people might think were appropriate in the general public for a living donor. And what we found were that a good proportion of the general public, up to 95%, felt that some sort of reimbursement for medical costs would be appropriate, or use of sick time or paid leave. And then others felt like a live donor could potentially be reimbursed through priority on a waiting list. And then when you started getting to other forms of compensation, they became a little bit less enthusiastic. But the point of this was that in the general public, people feel that there should be some sort of, or would not be opposed to some sort of reimbursement for live donor kidney kidney donors who are clearly giving a lot in doing and taking on risk when they donate. When we looked at in the same work, looking at the percent of people who were in favor of these types of reimbursement for live donors, we found that African-American individuals were more likely than white individuals to say that they would be in favor of something like a tax break, government direct payment, or employer compensation for live donors. Just highlighting the fact that potentially African-American individuals may have more financial concerns or be under more financial pressure than others, and that may play a role in their decision to donate a live kidney. So with that as the backdrop, the discussion around whether or not families, African-American individuals, are having family discussions about live donor kidney transplant, whether there are educational barriers to knowing about live donor kidney transplants, and whether or not there are financial concerns about live donor kidney transplants that could hinder African Americans from pursuing live donor kidney transplants. We did this study called the TALK study, and the TALK study was designed to improve communication, so the discussions, the logistical and financial barriers to live donor kidney transplantation in African Americans. I've provided you the rationale, but one of the reasons what we did was we wanted to study the effectiveness of two types of interventions, or one was sort of a behavioral and educational intervention, and then a financial intervention, and its potential to improve live donor kidney transplants among African-American individuals on the deceased donor waiting list. And one of the reasons we went after African-Americans on the deceased donor kidney waiting list was that, you know, as I said before, individuals who are on the waiting list have actually already overcome many barriers to receiving a transplant, because they've already gotten through the transplant evaluation, they've passed, they've completed their testing. And so, for all intents and purposes, they should be the ideal people to receive a live donor kidney if they have the opportunity to receive one. So we thought this would be a great population to study further. So in this study, we randomly, I'll go through it in a moment, but we randomly assigned individuals to receiving an educational video and booklet, which is called the TALK intervention, talking about live donor kidney transplant. versus receiving talk intervention plus a financial reimbursement for live donor kidney transplants compared to usual care. The talk intervention is a video and a book and a social worker intervention. So in the video depicts African-American and non-African-American patients and their families discussing live donor kidney transplantation, how they felt about it when they had to consider it, how they discussed it with each other, how they discussed it with their physicians, and the experiences they had with the whole process of getting evaluated and pursuing live donor kidney transplant. And the video also features healthcare providers who talk about important considerations relative to live donor kidney transplantation, including the number of medications patients need to confront, and surgical risks. It also talks about medical mistrust, which may be particularly relevant among African-American individuals who have been shown in many studies to have historical mistrust of healthcare environments and research. In addition to the video, there's a written booklet, which is designed to be used by patients and or their family members separately or together. And the booklet really educates, it's literacy tailored, and it educates individuals provides educational information about live donor kidney transplant. So what's it about, et cetera. What is a process? How do you go through that process? It encourages, though, at the same time, discussions primarily among family and friend for the patient with their family and friends and with the healthcare team. And it actually provides model examples of how a conversation could go. So giving patients concrete sort of examples of how to start a conversation, complete a conversation, and what to do when conversations may not go as planned. That video and book are paired with a social worker intervention, which is a 60-minute meeting with a transplant social worker in which the patient and the social worker discuss barriers to pursuing live donor kidney transplantation. And these barriers are barriers that the patient would self-identify. And then the social worker really walks the patient through those barriers and helping them kind of come up with their own solutions as to how they might overcome that barrier. It's a one-time meeting that could last up to 60 minutes, followed up with a family meeting. So the patient is invited to bring back family members and or friends, but to help talking about the barriers at the family level with regard to pursuing a live donor kidney transplant. And it's based off a behavioral framework called the Brief Solution Focused Counseling Framework. We had previously tested the talk intervention in another study called the talk study, which was conducted among patients who had not yet developed end-stage kidney disease. These were patients with progressive stage 4 CKD who were identified as likely to need a kidney transplant in the future and to be eligible for live donor kidney transplant by their nephrologist. And in that prior study, we had randomly assigned people to receiving usual care, the booklet and the video by itself, and the booklet and the video plus the social worker. And then we looked at whether or not patients pursued live donor kidney transplantation over a 6-month time period, having discussed live donor kidney transplantation with their family or their physician, and having started or completed a recipient evaluation. And in that study, what we had found was that 30% of individuals over a 6-month time period had begun the process of pursuing a live donor kidney transplant. But when they received the booklet and the video, 42% begun the process to receive a live donor kidney transplant. But when you paired the booklet, the video, and the social worker, you got the strongest effect with 58% of individuals pursuing a live donor kidney transplant. So we saw this as a promising intervention that we wanted to test out among African-American individuals on the deceased donor kidney waiting list, because again, as I said, we felt that that group was in the perfect situation to receive a live donor kidney transplant if they were able to find donors. So for this particular study, the TALKS study, we took individuals who were newly registered on the waiting list, African Americans, and we compared those no intervention to individuals receiving the full talk intervention, the educational and social worker intervention, and then the talk intervention plus a financial assistance intervention. And the financial assistance was targeted towards donors. And I'll talk about that in a moment. But this assistance would be an intervention to help live kidney donors, potential live kidney donors, overcome financial barriers to seeking a kidney transplant. The participant eligibility criterion, we recruited only adult African-American individuals. They were at Duke University, so it was a single site study. They couldn't have had a prior living donor kidney transplant, and they were English speaking. And then donors who participated in the study were contacted through the recruited potential recipients. So we contacted the patients, and the patients, if they were able to identify donors as part of the study who might utilize the financial assistance program, they would contact them themselves. So the financial assistance, the live donor financial assistance program was modeled after the National Living Donor Assistance Center at the time, but it was a little bit different. So the National Living Donor Assistance Center at the time was providing financial assistance for, I believe, up to 3 potential living kidney donors in the amount of $6,000 to help cover expenses like travel, reimbursement for other types of expenses related to live donor kidney transplant. But there was an income limit that the potential recipient had to be 300% poverty level or less. There had to be proof of a donor financial hardship required. And it covered travel, hotel, parking, and meal costs related to donor evaluation, surgery, and follow-up. It did not cover lost wages from work related to donor evaluation, surgery, and follow-up. It didn't also cover costs related to donor evaluation, childcare related costs. And in contrast, we offered in this study, the financial assistance was less, $2,100 total per potential recipient. But there were no income level limits for either the donor or the recipient. There was no need for a proof of donor financial hardship required. It did cover costs of travel, hotel, parking, and meal costs related to evaluation and surgery. It did cover lost wages from work, and it covered childcare related expenses related to the whole donor evaluation process. So they were similar, but there were definitely some differences. Our program was more had more allowances. For the study, we randomly assigned people to the interventions, meaning usual care, the talk intervention, which is the video booklet, and the social worker, and the third group being the talk intervention plus the live donor financial assistance. And our outcome really was focused on donor activation. We wanted to see if people received this intervention, would the donors be activated to step forward and donate a kidney? And so our primary outcomes were live donor kidney transplants, which we assessed via the medical records or self-report, the completed live donor evaluations, which would be a live donor coming to the center and completing their whole eval, and then live donor inquiries, which would be also recorded. That could be phone calls or contacts with the transplant center. And we recorded all of that, the primary outcomes, via medical record or self-report. And then our secondary outcome was whether or not individuals had discussions about live donor kidney transplant or had identified a live donor through their self-reports to us, the recipients saying that. And then we did some descriptive analyses over time, and we did time to event analyses for our primary outcomes. And we were powered to see statistically significant differences across the 3 groups. We accounted for attrition at our at follow-up. So I'm not going to, this is, I know, a very small slide, but it just shows our consort diagram, which is that we started off identifying 1,000, nearly a little bit over 1,000 potential participants, mailed them recruitment letters, 319 consented to the study, but some were withdrew before we actually started the study. 7 were excluded, and 4 we weren't able to reach after the initial contact. We ended up randomly assigning 300 individuals to the 3 groups: usual care, talk by itself, or talk plus the financial assistance. So there were 100 in each group. Our primary outcomes were measured through the electronic health record. So we actually ended up having 100% of follow-up for each of the 3 groups, because we had their health record data. We also conducted questionnaires about asking them about their behaviors. Had they discussed transplant with family members? Had they completed their evaluations? Had they talked with the physicians, et cetera? That we assessed via surveys at 4 months and 12 months. And we had about between 86 and 88% follow-up at the end of the study. I'm just going to run through briefly some of the salient characteristics of the study population. First, just to remember that all the participants were African-American individuals, self-identified. The average age across all three groups was around 52. We had 44% females and 56% males enrolled in the study. The population actually had a fairly high education level. I'd say 38% had a high school education. Around 50% had at least 2 years of college, and a little bit more. And if you added in those who had graduate professional school, it was nearly 60% of individuals. Most of the individuals were retired. And then in terms of the poverty, most of the individuals were not in poverty. 67% were not in poverty. We did have around 18% that said they were near poverty or poverty. Most of the individuals were receiving Medicare insurance, and 45% were married or living with a partner. 43% were divorced, single or never married, and 6% were widowed. We asked people about what family members they had, primarily because we were trying to identify the total potential immediate family donors, which we defined as their children, any siblings they had, a spouse if they had one, or living parents. And a majority of people had a median, so the median number of potential immediate family donors was 6. The group had fairly high health literacy, with 60% having greater than 9th grade health literacy, and also had good health numeracy. On the whole, the participants had been on the waiting list for less than a year. The median time was 0.8 years. And the majority of participants were already on in-center hemodialysis. Nearly 20% had not received kidney replacement treatment yet. So they would have been preemptive candidates. And then 4% were on home hemodialysis and 15% on peritoneal dialysis. So at the baseline, we asked individuals about their interest in receiving live donor kidney transplant and their knowledge of live donor kidney transplantation. And what this is the median interest on a scale of 0 to 10, with 10 being the greatest interest and 0 being no interest whatsoever. We asked overall, and then this is looking at the median interest among those in usual care, the talk, which is the video booklet and social worker, or the talk plus the financial and reimbursement. And what we find is that the median interest in live donor kidney transplant in this group was very, very high. It was 10 out of 10. Then we asked individuals about how much knowledge they felt they had at this moment about live donor kidney transplantation. And the answers were none in the blue, some in the orange, and a great deal in the gray. And you can see that overall, people, a majority of people said they felt they had some information, but and about 40% with a great deal, and that did not statistically significantly differ at baseline among the 3 study groups. Because we were providing the live donor assistance program, financial assistance program, we wanted to know people's awareness of live donor financial assistance programs in general across the country. And so we asked them, are you aware of any of these programs? And this again is overall, and then this orange is usual care. This is the talk group, and this is talk plus the financial support, and these are at baseline. And so we found that overall, about 37% of our participants were aware of any live financial assistance program. And then we asked them about the National Live Donor Assistance Center. 27% knew about that. And then we said, any donor using any of these programs on your behalf, and only 1% of the participants said that a donor was utilizing a program like that on their behalf. We also asked people, so we did this study and we wanted to see how many people actually utilized the intervention. So we did the study for a 12-month time period, and we wanted to see who actually used the video and who used the book and the social worker. So this overall is among people who were in the intervention groups. So among those who were randomly assigned to the talk, social worker, and book in the orange, 77% said they'd watched the video, 88% read the book, and 86% attended a social worker visit. And then among those who had the talk plus the financial support intervention, 66% watched the video, 84% read the book, and 91% met with the social worker. So reasonably high rates of utilizing the intervention, the talk intervention. But when we went to looking at the end of the study, who actually used the financial intervention, it was quite surprising in our mind, because we'd assumed that many people would seek to utilize this intervention. And what we found were, by the end of the study, only 2 potential donors were identified through the patient participants and requested any financial assistance. 1 potential donor requested reimbursement for a hotel stay in Durham, where we're located, for a total of $100, and another requested reimbursement for laboratory bill for a total of $586. But so of all of the 100 people that were randomly assigned to receive the financial assistance intervention, only 2 potential donors were identified through those 100 people to participate in that part of the intervention, which was quite a surprise. So come to the end of the study, and we're looking at the primary outcomes, which were included live donor inquiries to the rates at which live donors would approach the transplant center, live donor evaluations at 12 months. And so the way we broke this down was to look at individuals who had at least 1 inquiry overall by usual care among the talk group, which was again the video booklet and the social worker, or the talk plus the financial support intervention. And we found that overall throughout the 12 months, rates of live donor inquiries were low, so that only 12% of the participants actually had a live donor inquiry over the course of the study, and that the rate was no different among the 3 intervention groups. We looked at how many people had, of those who had an inquiry, how many had 0 inquiries, or overall we looked at who had 0 inquiries, 1, 2, 3, and 4. And again, you could see that the majority of people had no inquiries. There were more people who had 1 inquiry, but after 1, it certainly dropped off. And then this is looking at live donor kidney evaluations. Overall, most individuals had 0 live donor kidney evaluations. 5% had 1, and 1% had 2. But you could, and that did not change across the three groups. Was no different across the 3 groups. This looks at the composite of those 3. So it's the cumulative incidence of any donor activation events, which includes the donor inquiries and the donor evaluations. The black line is usual care. The green line is those who were receiving the social worker video book. And the blue dotted line is that social worker video book plus the financial assistance, and showing essentially here that the lines cross and there was no difference in live donor activation events over the 12 months. And as expected, then live donor kidney transplants were no different between the 3 groups either, where in terms of live donor kidney transplants, 1% of the participants received it overall, with similar percents across the 3 groups. 17% received a deceased, over all transplants was 17% among overall, and that was no different across the 3 groups. We also asked individuals again about whether they had pursued live donor kidney transplant themselves by discussing it with their families, or having a discussion with, or having identified a potential donor. And so we categorized people as having low pursuit if they had not discussed live donor kidney transplantation with their family at all, moderate if they discuss it with the family, and high if they'd already identified a potential donor. And what we found were that at baseline, many people had not discussed live donor kidney transplantation with their families at all, and 18% had discussed it with their family, and 72% said they'd identified a potential donor. By 12 months, and that was no different across the three groups. By 12 months, fewer people had not discussed it with their family at all. More, slightly less had said they had a new opportunity to discuss it with their family during the 12 months. And 60% said they'd identified a potential donor, yet we still had not had those activation events. So the conclusions that we drew from the study were that educational, behavioral, and financial support interventions did not improve live donor activation compared to usual care. We didn't see any increased rates of the inquiries or the evaluations, and the interventions had no impact on getting the potential recipients activated. And this was in contrast to what we'd seen in the prior study, where when we'd done this intervention among people who were not on the waiting list, we saw that stepped effect, that people who actually got the video and book were more likely to pursue live donor kidney transplantation. And then when they got all three, they were even more, the booklet, video, and the social worker, they were even more. But we didn't see that effect in this population on the waiting list. And then again, we were surprised to find not only were people unaware of financial assistance at baseline, but when we offered those financial assistance interventions to potential recipients to offer to potential donors, they weren't utilized. So I put this little picture here because we keep trying to find interventions that are going to work to improve live donor kidney transplant among African-American individuals who we see that the rates of receipt, the disparities in the receipt of this treatment are getting worse. But these interventions missed the mark. In my mind, I think that this implies that probably, particularly for individuals who are on the waiting list already, recipient education and family discussion is not enough to influence the donor behaviors, and that working through recipients to see if they can offer or improve potential donors' awareness of a financial intervention may not be an effective means to solicit or to recruit potential donors for a patient who needs a transplant. And donors may need substantially more support. They may need other people to reach out to them. And then offering people money may not actually work, or people may not know how to use it. We were really, again, surprised that people did not use the support. And it brings up the question as to whether or not the national programs actually are being utilized as well as they could be, and is that really, whether or not the current approaches are effective at all to address racial inequities in live donor kidney transplantation. The national data showing that rates of inequities have gotten worse over time suggests that they may not be effective. So I'm going to end there, stop sharing so we can have questions and discussion. And I'm happy to take any questions folks may have.
Thank you so much, Dr. Boulware, for that excellent presentation, for sharing all that experience. I see that there's a couple of questions on the Q&A session, but just before we kind of launch into that, I thought I'd sneak in a question of my own. So you mentioned earlier on that the TOX study was actually done a couple of years earlier prior to this particular publication on patients who are not yet on the transplant waitlist, and it was looking primarily at patients with stage 4 or higher CKD. And it looks like in that particular study, there was a positive influence of this social worker intervention, whereas we're not seeing that here with this last study. Can you hypothesize as to why there is this difference between the patients who are already on the waitlist versus those who are on CKD? Are these interventions better used when it intervenes earlier in the course of kidney disease? Do you think that's the explanation?
Yeah, we've done a lot of thinking about this, and I do suspect that when patients are earlier on in their kidney disease, when they haven't already settled in on a treatment like dialysis and maybe adjusted to it after a few months, that they may be more motivated to actually pursue this treatment, and the optimism around it, and the, maybe more motivated, and maybe family is motivated, and just kind of the fear of sort of approaching end-stage kidney disease may help to move them forward a little bit more. It's well known that when people initiate dialysis, that first off, it's very difficult psychologically, physically, and that people, are trying to adjust to this major change in their physiology and in their lives. And it may be that people are just simply tired, and that they've gotten to a certain point, and the motivation to actually overcome what it takes to get into the transplant center, to reach out to people, just may be very, very high. It may take a lot of activation energy when they already are on a treatment at that point. So my hypothesis is that, yes, it's important to get to people early, at a time when they're feeling healthier, when they don't know what the future is, and they're not, I think there's an opportunity to get everybody activated around that, and they may have more energy in general to do the engagement.
Great, thank you very much. So I may just launch, if it's okay, into some of the questions that the audience has posted. The first question comes, it says, in our work, we have found about half of the transplant-related knowledge differential between African-American, Caribbean, and Black individuals versus white patients may be explained by mistrust. Do you have similar data? How are you addressing the mistrust in the healthcare system? And then the last part of that question is racially or culturally concordant education potentially more effective in this context?
Really interesting question. So the first part is about whether mistrust explains the educational differences. So in all of these studies, we actually do measure mistrust that I've done. And we do find, and it's well known, that in diverse populations, particularly Black American populations, we find that there are higher levels of mistrust in healthcare in general. We actually found that for this group of participants in this study, that the trust levels were fairly high. So it may say something about the kinds of patients that get to the waiting list in the first place. As you noted, there were, or as I noted, this was a pretty well-educated population. There was low rates of poverty, and that may just reflect the transplant, the whole screening and evaluation process in and of itself, who's allowed to get to the list. And so we found that actually mistrust levels were not that high in this particular population. So that wouldn't have explained it. I would say that mistrust may keep people from coming through the door, but it doesn't necessarily keep people from getting educated once they're in the door. So when in one of the studies I showed, where the rates of knowledge were lower among Blacks compared to other individuals, that was all in the context of care. So it brings up the question as to, are people receiving the types of education that they need? And with regard to sort of culturally concordant education, I don't believe that there is such a thing as culturally concordant education, in that I think there's probably a set of information that everybody needs to have about kidney transplantation, no matter what their culture is. And then there may be some culturally related concerns people may have, for example, diet or things like that, that may actually change by culture. But in my view, there's education is education, and people need to know about treatments. They need to know what they need to do to get a treatment, and that we need to make sure that we're consistently offering education. The education in and of itself, the type of education being offered, to me, is not the problem. What the problem is that the education is not being offered equally to individuals. And that's what I believe yields the inequities in knowledge.
Great, thank you. And another question was, in some of the first slides that you have presented, there were questions related to this discussion of transplant with family amongst African-American families. Did they also survey other races or ethnicities for comparison's sake?
No, so we did not. And that was a study of African American individuals with end-stage kidney disease. That it was actually a study done for genomics, and we took advantage of that study design to ask these individuals about the discussion rates. So it would be nice to have comparison rates, but we didn't have it for that. I think the take-home message for that was that whether or not it was different, that it was an inadequate, that at the end of the day, we needed to have more discussion across the board within these African-American families.
I actually, Brian, there's a couple questions in the Q&A chat, but I just had a question that I want to pose before we keep moving, and I want to see if Dr. Henderson has any ideas about this. I'm sorry, the fire alarm in my apartment is going on. I'll come back if you want to take over, Brian.
Okay, looks like there's a little bit of a mishap. There's a question there asking about whether there is a cap on the financial assistance and how many and a cap as to how many donors a recipient could have and still receive the financial assistance. I think you mentioned something about the NLDAC had up to 3 donors who can be compensated up to $6,000. But for the purposes of this particular study, was there a cap on how many donors each recipient could have?
No, there was no cap, but there was a total cap on the total amount of reimbursement a person could have per family. So they could get $2,100 per family, no cap on the number of people who could be taking part of it. So it's kind of like a bank of money that was available. But again, it wasn't utilized, which was fairly surprising to me. So.
Great. I wanted to ask a question about, we often talk about, and this will be a question for both Dr. Boulware and Henderson, but we talk about delivering healthcare in a culturally competent, sensitive manner. How is that a skill that can be taught? Or in other words, does culturally competent care, can that only be provided by a provider who shares a very similar social, cultural, or linguistic background with the patient in order for it to be effective, or can anyone be taught to deliver culturally competent care?
I'm going to let Dr. Henderson take the lead on that first.
That's a really good question. I think, have to give me a second, kind of stumped me with that one. I've never been asked that. I believe that if we provide individuals with kind of that training, of how, because I think the biggest thing is respect for persons and respect for culture. And that's something we can provide and we can teach to other people. And that's something we would want everyone to kind of embody, correct? So I think it can be taught. It doesn't have to be just because, let's just say I'm a Black practitioner, which I'm not, and it's a Black patient, that like we will, I'll automatically be the one person who can be the arbiter of like kind of creating that trust through that cultural competency. I think that that's something that we all can kind of take on in the ways in which we learned respect for differences, respect for person, just in general, and respect for culture, and really putting in that time to create that trust. And you do that through creating respect and having an understanding of folks who may not look like you. And so, yeah, that's my response.
And I completely agree with that. We can't default to a patient needs to have a Black patient needs to have a Black doctor, needs to have a Black surgeon, needs to have a Black everything, or we're not going to be living in an integrated society. The point of this is actually to look at structural inequities, and in order to overcome structural inequities, race-based structural inequities, everybody has to be able to deliver culturally competent care, which, as you said, Dr. Henderson, the basic respect for persons. And really, this is about trying to overcome one's implicit biases and make sure that you're addressing the needs that you would address somebody, your own grandmother, your own mother, your own father, your own spouse. So, part of what behooves us within the healthcare system is to begin to break down whatever factors we may not be aware of when we're interacting with individuals who come from some other different background, no matter what that background is, to ensure that we're offering, high quality care in every dimension.
Okay, great answers. Thank you so much. There is another question here from the audience about how do we get around the barrier of offering financial assistance and not make it seem like we are basically paying for somebody to donate a kidney?
We're not paying for them to donate a kidney. We're providing resources to support the fact that they are undergoing substantial loss and sacrifice to provide a kidney. So it's certainly illegal to incentivize a kidney donation by paying someone, but here you're reimbursing somebody for costs that they are subject to for the sake of a transplant. And we know that individuals who are from diverse backgrounds, particularly Black individuals, Indigenous individuals, have less wealth, family wealth, individual wealth, and are not able to manage these types of costs just willy-nilly. So if you consider it to be some sort of incentive by paying someone back for something that they've already given, then that changes the rules completely. But these aren't incentives. We're leveling the playing field so that anybody could have an opportunity to have these costs reimbursed, particularly those that cannot afford them. Otherwise we're saying that you can only get these things if you're rich. That's obviously a societal consideration, but these are reimbursements. They're not incentives. We're not offering people additional money, and we're not rewarding them by doing this. They're taking on substantial risk.
Right. I may, in the interest of time, combine some of the questions, but I think if I can paraphrase some of the things that were out there, do you think the fact that the interventions did not show a difference between the groups was related to the fact that it was the follow-up time was only 12 months? Had you stretched it out to a longer period, do you think you potentially could have seen a difference?
So I didn't mention that we did have passive follow-up of the outcomes for up to 2 years, and we didn't see any different. So unfortunately, no. And it may mean that you need more intensive. Remember, we did the intervention once. That social worker intervention was a one-time intervention, kind of a brief episode. And it may mean that there may be more intensive interventions that are needed, multiple meetings, multiple discussions to really navigate people through the process. I mentioned that as a potential limitation of the intervention as it was developed. We're now studying in another study, a more intensive similar intervention, but with multiple touches, navigation, longer term engagement with participants to see if that could help.
Great, thank you. And we may have time for one last question. One of the audiences had posed, well, actually, it's a complex 3-part question. So I may just get through the first 2, but did the medical social workers in the talk study receive any specialized training or instructions?
Yes, they did. It's published online. Actually, we do have a publication on the talk study and how social workers actually can deliver it. So if you look up the talk intervention, it's called Putting It Into Practice. It's developed specifically for implementers to implement it. Okay,
and I think that probably answers one of the other parts of that 3-part question, because the audience is asking whether the booklets and the videos that were used as part of the talks intervention is actually publicly available.
They are publicly available. I guess I'll figure out how to provide the web link. I should have provided it, but they are publicly available.
Great, thank you. There's a lot more questions that are out there, and I apologize to the audience that I'm not able to kind of fit every single one of these in here. But I think we're gonna be up on the hour and we'll have to wrap up at this point. So Brian, I'm gonna hand this back to you.
Well, thank you so much, Dr. Lee. And Dr. Boulware, we will be happy to follow up with you after this session to make sure that we can post the links, any links you want, any information you want onto the registration page that folks used. Now, to wrap things up, AST would like to thank Drs. Boulware, Henderson, Daloul, and Lee, and all of our attendees for today's session. Please remember to complete your evaluation survey and visit myast.org/journal club to view our video archives and register for future upcoming journal clubs. For those questions we did not have time for, we will either take the time to answer them individually offline, or we'll post the full question with the answer on the website following the journal club. To learn more about the AST communities of practice, please visit myast.org/COPS or connect directly to the Living Donor Community of Practice or Psychosocial and Ethics Community of Practice hubs. Thank you again for today's great and excellent session.